All right, let's talk about something incredibly serious. A pregnancy that starts in the wrong place. I mean, a journey that goes way off course, with potentially life-threatening consequences. We're talking about an ectopic pregnancy. It's a true medical emergency, and tragically, a leading cause of maternal death in the first trimester. So in this explainer, we're going to break it all down. What happens, why it happens, and maybe most importantly, where the greatest dangers really lie.
So what's at the absolute heart of this condition? Well, it really all comes down to one thing: location. You see, in a normal, healthy pregnancy, a fertilized egg makes a very specific journey. It travels down the fallopian tube and implants itself in that rich, prepared lining of the uterus. But with an ectopic pregnancy, that whole journey gets thrown off track. The implantation happens somewhere else entirely, somewhere outside the uterine cavity. And believe me, that single difference in location changes everything.
And this is exactly why it's so critical to understand. The places where these implantations happen, like the fallopian tube, they just aren't built to support a growing pregnancy. Not at all. They can't expand, they don't have the right kind of blood supply, and so as the pregnancy develops, it puts the organ it's in at a huge risk of rupturing. And that rupture, it can cause a catastrophic internal hemorrhage. We're talking about a full-blown, life-threatening emergency.
Okay, so to really get a handle on this, here's how we're going to walk through it. First, we'll cover what it actually means for an implantation to be outside the uterus. Then, we'll dig into why that journey fails. After that, we'll look at a catalog of risk factors, then a map of all the different places these misplacements can happen, and finally, we'll zero in on the really high-stakes anatomical sites.
All right, let's jump right into part one, defining the condition. So what are we really talking about here, and, how common is this?
So the clinical definition is pretty precise. An ectopic pregnancy is a pathological condition where a fertilized ovum implants and starts to develop outside the normal uterine endometrial cavity. Really, it's that one little word, outside, that is the root cause of the entire medical emergency.
Okay, so how often does this actually happen? Well, it's estimated that about 1 to 2% of all pregnancies are ectopic. Now, I know, that might sound like a small number, but think about the sheer number of pregnancies that happen worldwide. That 1 to 2% quickly becomes a really significant and very dangerous clinical challenge.
All right, that brings us to the really crucial question, right? What exactly goes wrong? Why does that fertilized ovum fail to make it all the way to the uterus?
Well, for most ectopic pregnancies, the core problem is what we call impaired transport. Basically, the fertilized egg gets delayed or just plain stuck on its way through the fallopian tube. It's like a traffic jam, and that forces it to implant right then and there, long before it ever reaches the safe harbor of the uterus.
And the number one cause of that traffic jam? It's a condition called pelvic inflammatory disease, or PID. Think of it like a chain reaction. It usually starts with an infection, something like chlamydia. That leads to salpingitis, which is just a fancy word for inflammation of the fallopian tube. Then, as the tube tries to heal, it can develop fibrosis and scarring, which physically narrows the pathway. But here's the really critical part. It also damages the delicate cilia. Those are the tiny hair-like structures that are supposed to push the egg along. So you end up with a blocked path and a broken transport system. It's just the perfect storm for trapping a fertilized egg. But PID isn't the only thing to worry about. For instance, previous surgery on the fallopian tubes and leave behind adhesions or just change the tube's shape. Some people are born with congenital abnormalities, like tubes that are extra long or twisty, which naturally slows things down. Endometriosis is another one. It can cause fibrosis and adhesions. And this is a big one. If you've had an ectopic pregnancy before, your risk goes up dramatically. We're talking 6 to 10 times higher because the original damage is often still present.
And it's not always about direct damage to the tube either. Other factors can come into play. For example, certain hormonal shifts, maybe from progesterone-only contraceptives or even IVF treatments, can mess with the tube's muscular contractions, that motility. Then there's the IUD or IUCD. Its whole job is to prevent implantation inside the uterus. So, in the rare case that a pregnancy does happen with an IUD in place, there's a higher chance it's going to be ectopic. And sometimes, the issue might even be with the embryo itself. It could become invasive too early and try to implant before it's even finished its journey.
Okay, so we've covered some of the specific causes. Now for part 3, let's zoom out a bit and look at a broader catalog of risk factors. We're talking about patient characteristics and habits that can increase the chances of this happening.
So, there are several general factors that are linked to a higher risk. Age over 35 is one. Smoking is a really big one, and we know exactly why. Nicotine is toxic to those tubal cilia and it reduces motility. So it directly messes with that transport system we keep talking about. Having multiple sexual partners is also a risk factor, mainly because it increases the risk of getting PID, which we already know is a leading cause. And then other factors, like low socioeconomic status and a history of infertility, are also strongly linked.
So, we've talked a lot about the why. Let's move on to part 4 and explore the where. It's time to map out the specific anatomical sites where these pregnancies can actually implant.
And when you look at the data, it's incredibly clear. The vast majority, we're talking about 95% of all ectopic pregnancies, happen somewhere inside the fallopian tube. But that leaves this other critical 5%, and those happen in other, much rarer, and often very dangerous locations. Okay, so let's zoom in on the fallopian tube. The most common spot by far is the ampulla. This is the wider, kind of outer part of the tube. And because it's wider, it has a little more room to expand. This means a rupture here tends to happen a bit later, usually somewhere between 6 to 8 weeks.
Now, let's contrast that with an isthmic pregnancy. This happens in the isthmus, which is the much narrower section of the tube closer to the uterus. Because it's so narrow, there's just very little room for anything to grow. This means a rupture happens much earlier, think 4 to 6 weeks, and it often comes with more severe, rapid bleeding.
The other tubal spots are the fimbrial end, that's right at the very tip, where sometimes the pregnancy can actually be expelled out into the abdomen, which is called a tubal abortion. And then there's the interstitial or corneal portion. Now this one is really unique because it's the part of the tube that literally passes through the muscular wall of the uterus itself. And that little detail brings us to our final and most critical section.
Right, because even though most ectopic pregnancies are in the tube, not all locations are created equal when it comes to risk. Let's talk about the really high-stakes anatomical sites.
So when you look at all these possible locations, where is the risk of a truly catastrophic hemorrhage the absolute greatest?
And the answer is that interstitial or corneal pregnancy we just mentioned. Here's why it's so dangerous. Because it's surrounded by all that thick uterine muscle, it can actually grow for a lot longer, sometimes delaying a rupture until 8 or even 16 weeks. But its location is right next to the major uterine blood supply. That means when it does finally rupture, the hemorrhage is absolutely massive. It is catastrophic, and it carries a tragically high mortality rate.
There are other incredibly dangerous, though much rarer sites too. A cervical pregnancy, for example. That's where implantation happens in the fibrous tissue of the cervix. The bleeding can be uncontrollable because, unlike the uterus, the cervix can't contract to clamp down on the blood vessels. Then there's a cesarean scar pregnancy. This is where implantation happens right in the scar tissue from a previous C-section, which creates a huge risk for uterine rupture.
So if there's one key takeaway on location, it's this. The most common site is the ampullary part of the tube. Simple enough. But the most dangerous ones, the ones with the highest risk of mortality, those are the interstitial and, though they're super rare, abdominal pregnancies. And all of this leaves us with a really critical thought for the future. We know that medical interventions like IVF and C-sections are becoming more and more common, and we also know that they're linked to some of these rarer, high-risk types of ectopic pregnancies. So the question is, as these practices continue to rise, how is that going to shift the whole landscape of this condition? And what new challenges is that going to create for the clinicians who are on the front lines trying to manage this life-threatening emergency?